Hi everyone, I'm Avery Carpenter and I'm going to be discussing the latter part of Chapter 10. The latter part of Chapter 10 discusses and talks about health insurance. Why is it important to learn about health insurance as a nurse? Well, there's a quote in the book that says, to provide care and appropriately advocate for patients, all nurses need at least a basic understanding of healthcare costs. They also need to know how reimbursement strategies directly and indirectly affect their practice. We're going to begin talking about Medicare. Medicare is health insurance mainly for patients 65 years and older. The federal government became a major insurance of healthcare with the advent of Medicare and Medicaid in the 1960s. Medicare is a health insurance program for the elderly, like I said, older than 65 years old, for a certain group of people with catastrophic or chronic illness, regardless of age. Over 83% are elderly, and more than 16% are disabled. 0.9% are end-stage renal failure. Due to the increase of the amount of baby boomers turning 65, Medicare is expected to grow at an average of 6,700 to 11,000 people per day. There are 4 parts of Medicare. Part A, which is a hospital insurance program. Part B, which is supplementary medical insurance that provides outpatient care such as x-rays, laboratories, MRIs, things of that way. And PCPs also. Part C, which allows choices for participating in managed care plans, which we will talk about later. And Part D, which allows patients to purchase at least limited prescription drug coverage. Now we're going to talk about Medicaid. Medicaid provides medical and long-term care coverage for people with disabilities. Not everyone is eligible for Medicaid, so I provided a link in the notes section of the PowerPoint that shows exactly who is eligible for Medicaid in Mississippi. Some examples of who qualify include infants and children up to age 19. Now, there are stipends on who qualifies. They have to meet the appropriate income limits. They have to be below federal poverty level. I think make less than $1,300 a month. So another example, pregnant women with income limits under 194% of federal poverty level. Parents or caretaker of minor children who are deprived of the support of one of both parents due to the disability of a parent, the death or continued absence of a parent, or parents who are unemployed and have very low income. Okay, that is Medicaid. Like I said, if you want to see exactly who qualifies or is eligible for Medicaid in Mississippi, there's a link provided in the notes section of the PowerPoint. The prospective payment system. As healthcare skyrocketed and more people did not have healthcare insurance or had limited coverage, began accessing Medicare and Medicaid services, healthcare providers began to look at it as a way to get more money. They started looking at the government. As hospitals joined the prospective payment systems, they were to receive a specified amount for each of the Medicare's patients' admissions, regardless of actual cost. Hospitals began to join the PPS system, and this led to decreased length of stays for patients. Some would say it decreased the quality of care as patients were being discharged prematurely. The managed care movement. Managed care is a system that attempts to integrate efficiency, care, access, and cost of care. Common denominators used in managed care include the use of PCPs as gatekeepers, a focus on prevention, a decreased emphasis on inpatient hospital care, the use of clinical practice guidelines for providers, and selective contracting, which basically says that providers agree to lower reimbursement levels in exchange for patient contracts or an increase in adequate patient population. Frequent hallmarks of managed care include the utilization review, which is a process used by insurance companies to assess the need for medical care and ensure that payment will be provided, and capitation, which is where providers receive a fixed monthly income regardless of services used by patients during the month. This ensures the patient receive the essential services to stay healthy or to keep from becoming ill, but to eliminate the unnecessary use of healthcare services. Types of plan. The most common type of managed care organization is a HMO. This is a corporate body funded by insurance premiums or prepaid healthcare plans. To join a Medicare Advantage plan, patient must have both Medicare Part A and Part B. The pros of managed care. So one of the pros is decreased healthcare costs. As we know, healthcare costs these days, they can be extremely high, and because healthcare costs can be so high, some patients don't seek healthcare, especially if they don't have insurance. They provide broader benefits for patients, and they appropriately shift care from inpatient to outpatient settings. And they have higher enrollee satisfaction levels and typically have small co-payments. Some of the cons of managed care include loss of existing physician-patient relationships, limited choice of physicians for consumers. So consumers of managed care, they won't get to pick, they won't have a broader network of physicians to pick from. They're basically giving up their flexibility of picking their own physicians and who they get to see and where they get to go, but basically for a smaller co-payment, smaller payments. They have a lower level of continuity of care. They have reduced physician autonomy, longer wait times for care, and everything must be pre-approved or pre-authorized by the gatekeeper, which is the PCP, or like things such as surgeries have to be pre-approved and have a second opinion. Some declines in managed care participation have occurred in part because they are no longer significantly less expensive for consumers to purchase. Providers have grown kind of frustrated with managed care because of the need for justification of services and the fact of having to get second approvals on things such as surgeries, and this is known as managed care backlash. The result has ended in managed care organizations saying yes to more services, and in result, the patients or consumers who have these managed care organizations are having higher payments, higher co-pays, higher deductibles, higher premiums. And so that doesn't necessarily mean the managed care organizations are going anywhere anytime soon. They're still around, and at a substantial amount. People are still using them. So The Affordable Care Act, as we all know, President Barack Obama initiated this. He initiated this in March 2011, and the act included a new Patient Bill of Rights, which included a provision for Medicare beneficiaries to get preventative services for free, discounts on brand name drugs for some patients in Medicare Part D. It included greater access for more Americans to have affordable health insurance. So those who maybe did not have insurance before, or had a insurance that they couldn't quite pay the copays every visit, or the premiums or deductibles, this act gave greater access for more Americans to have health insurance. Now, I looked up an article about Obamacare, and it's in this article, it's on CNN Money. I provided the link in the PowerPoint, but it is actually saying that Obamacare has more, or Obamacare advocates, or people who have Obamacare, pay more than those who have different types of insurance. I provided some charts in the PowerPoint. For example, those who have an employer health insurance paid $31 for brand name drugs. Those who have Obamacare paid $40. Saying those who have Obamacare pay more than those who have an employer health insurance. For example, those who have the employer health insurance pay $31 for brand name drugs, and those who have the Obamacare Silver plan, which is the most popular plan, pay $47 for brand name drugs. Copays for those who have employer health insurance pay $36 to see a specialist. Those with the Obamacare Silver plan pay $56 to see a specialist. So it just brings up the question of, is it really more affordable? Deductibles for employer-based health insurance is $1,217. The deductibles for the Obamacare Silver plan are $3,453. So, it makes me question, well, is it really more affordable? It's better than no insurance, but are people really able to afford these payments? It just brings up the question for me. Healthcare reform. There are different types of healthcare reform. One included is bundle payments, which is where providers agree to accept a discounted payment either retrospectively or prospectively, which represents a coordinated plan of care for patients over the course of a single episode of an illness. And you have the accountable care organizations, which are groups of providers and suppliers of service who work together to better coordinate care for Medicare patients. This includes a group such as physicians, nurses, nutritionists, social workers. All of these people work together to provide services. Hospital value-based purchasing. They pay inpatient acute care services partially on care quality, not just on the quantity of the services provided. Providers are held accountable for the quality and cost of healthcare services they provide by a system of rewards and consequences. The medical home. This is designed around patient needs and aims to improve access to care. Now, improved access to care includes things like extended office hours, electronic health records, and increased communication between providers and the patients, either through email, telephone, via websites, or things like that. Increased care coordination and enhance overall quality while simultaneously reducing costs. This also allows on a team of providers such as physicians, nurses, pharmacists to integrate all aspects of healthcare. Providers usually like or encouraged to join the medical home healthcare reform because of financial incentives. They focus on the quality of the patient, and financial incentives are given to the providers based on the quality of care. Managers must understand planning and healthcare reimbursement, be aware of their budgetary responsibilities, and be cost effective in meeting organizational goals. They must be able to articulate unit needs through budgeting, must be skilled in budget control. Nurse managers basically have to know how to budget the unit costs without affecting patient care and putting patient care without cutting so much back that it affects patient care. I'll put it that way. Okay, that was chapters 219 through 220. Well, pages 219 through 229 in the book. If you want to go back and maybe hit some spots that I missed, like I said, click on those links. And for any questions, just